Hello. Today we're going to learn how to interpret EKGs. We're going to analyze rhythm strips. So let me back up here to the beginning. All right, so we're going to talk about electrocardiograms. So an electrocardiogram records the electrical activity of the heart. And what it's actually recording is the movement of ions that create electrical changes on the surface of each cardiac cell. And the EKG, sometimes we call it EKG, sometimes ECG, means the same thing, measures movement of the electrical charge. So let me show you a picture. So this is the cardiac cell. When the cardiac cell is at rest, it has mostly potassium inside the cell. And outside the cell, the major ions are going to be sodium and calcium. And this is when the heart is in the resting state, when it's in the polarized state. And then when it depolarizes, when the heart contracts, sodium and calcium enter the cell through sodium calcium channels, and potassium exit the cell. This is when it depolarizes, when it contracts. That's how come when you give somebody a calcium channel blocker, it blocks those calcium channels that allow the calcium to go into the cell. And so therefore it decreases heart rate and it decreases contractility, right? Because the more potassium, the more calcium that goes in the cell during depolarization, the heart is going to contract. And then repolarization, during this time, our heart is vulnerable, and it corresponds with the T wave on the EKG. And during that time, the ions are in flux. The potassium is going back into the cell, the sodium and calcium is leaving the cell. And we call that repolarization. And each one of these actions corresponds with a part of the EKG. So the P wave is atrial depolarization. The QRS is ventricular depolarization. And the T wave corresponds with repolarization when a heart is vulnerable. And that's going to become important when we talk about code management. Yeah, so our heart is vulnerable here during the T wave because it corresponds here with repolarization. So what we're actually seeing when we're looking at these waveforms is what's happening to the ions in the cardiac cell. That's what we're seeing on the EKG. Now, in order to get the EKG waveform, we need electrodes. Electrodes are adhesive pads that contain a conducting gel. And when two electrodes are placed at a distance from each other, that's called a lead. So in this case, there's a 3-lead system. From here to here is a lead. From here to here is a lead. And from here to here is a lead. So this would be a 3-lead system. And then the electrodes are connected to a monitor with lead wires. This happens to be a portable monitor, often called a Holter monitor. Holter is a brand of a portable monitor. And sometimes it's hooked to a bedside monitor, but you're going to need these wires, these lead wires that are going to hook up to the monitor to be able to see the EKG tracing. So on a 3-lead system, there are 3 electrodes that are placed on the chest. These are not the correct colors of the 3-lead system. And then from these 3 points, 3 leads are generated. Like I said, from here to here is a lead, from here to here is a lead, and from here to here is a lead. And the color should be white on right, black on left, and I always remember red heart. So the red is supposed to be on the left. So these colors are not correct. So each lead is simply an electrical comparison of 2 points on the chest. Now, when you look at a 12-lead EKG, it's looking at the heart from 12 different directions. In this 3-lead system, it's looking at the heart from 3 different directions. On a 12-lead EKG, sometimes the QRS is not a positive deflection. and that would be normal for some leads. But if the charge is going to from a negative to a positive, you're going to see a positive deflection of that QRS. And so here's lead one. Lead one is looking at the heart from here to here, and it goes from a negative to a positive. Therefore, on the 12 lead EKG, lead one is a positive deflection. And these are the correct colors: white on right, black on left, red heart. And then here, you see lead two, and lead two is looking at the heart from here to here. And it also is going from a negative to a positive. Therefore, you have a positive deflection of lead two. So here is the placement of the electrodes. So I always remember white on right, black on left, red heart. That's how I remember it. Some people like white over right and black smoke over red fire. I like white on right, black on left, red heart. And then here's lead three. Lead three looks at the heart in this direction. It's also going from a negative to a positive, therefore it has a positive deflection. So lead one is looking at the heart this way, lead two is looking at the heart this way, and lead three is looking at the heart this way, and lead two is looking at the heart this way. So we're looking with 3-lead system, we're looking at the heart in 3 different directions. And we called those 3 leads, leads 1, 2, and 3, Einthoven's triangle, because it's looking at the heart kind of in a triangular pattern. Yeah, so looking at the heart this way, and this way. Now, you determine what lead you want the EKG to show up on the monitor, on the telemetry monitor. The computer inside the EKG monitoring equipment switches the roles of the electrodes automatically, so you don't have to switch those leads around. If you want to see if it's on lead 1 and you want to see lead 2, you just press the button on the monitor and it will switch it for you. So you don't have to move those leads around if you want to change the settings to see the leads. Now, these modified chest leads are not on a 12-lead EKG. These is a 5-lead system, and usually in tele, we're going to see this 5-lead system where now you can see these modified chest leads. And the way that you put the 5 leads on is, again, white on right, black on left, red heart. Brown in the middle, the green one left over. So white on right, black on left, this should be brown in the middle, red heart, green left over. White on right, black on left, brown in the middle, red heart, green left over. Now with this 5-lead system, one of the leads that we can visualize on the monitor is MCL1. MCL1 kind of wraps around the heart. So the charge kind of wraps around the heart like this, and so therefore it has a positive and a negative deflection. So usually on telemetry, lead 2 is being monitored, and MCL1 are usually the 2 leads that are being monitored on the monitor. And this one's MCL6 that's also can be obtained from a 5-lead system, and it's looking at the heart in this direction. So again, white on right, black on left, brown in the middle, red heart, green one left over. So the modified chest leads are not on the 12-lead EKG. So leads 1, 2, and 3 are on the 12-lead, and these augmented leads are on the 12-lead. These augmented leads are called augmented vector to the foot, augmented vector to the left arm, augmented vector to the right arm. What vector means is a force applied in a specific direction. So with these augmented leads, they take 2 leads and they average those 2 together against the 3rd lead. So for example, augmented vector to the foot is taking the average of these two leads, and it's looking at the heart in this direction. Augmented vector to the right arm is taking the average of these 2 and it's looking at the heart in this direction. Augmented vector to the left arm is taking the average of these two, and it's looking at the heart in this direction. So when you look at leads 1, 2, and 3, and AVR, AVL, and AVF, the augmented leads, that makes 6 leads, right? Those 6 leads are called the limb leads. And we're going to talk about why they're called the limb leads in a minute. So here we have augmented vector to the foot. So it's the average of these two, and it's looking at the heart in this direction. It has a positive deflection on the 12 lead EKG. AVL, augmented vector to the left arm. It's taking the average of these two, and it's looking at the heart in this direction. This is one that kind of wraps around the heart, so it has an upward and a downward deflection. And that would be normal on a 12 lead EKG for it to go up and down. AVR is going from a positive to a negative. Therefore, it has a negative deflection on the 12 lead EKG, and it would be normal for the QRS to be upside down in AVR. So AVR is looking at the average of these two, and it's looking at the heart in this direction. And so we said that leads 1, 2, and 3, AVR, AVL, and AVF, are the limb leads. Why are they called the limb leads? Because we get these leads, these EKG tracings of these leads by placing the electrodes on the limbs. So you put an electrode on the right arm, on the left arm, on the right leg, and the left leg. And then you can get these 6 leads from those 4 electrodes. Yes? So that's why we call those the limb leads. This slide, no need to know. We're not going to go over that slide. And then you have 6 precordial leads. So you have the 6 limb leads and the 6 precordial leads, and that makes the 12 lead system. What are the precordial leads? V1, V2, V3, V4, V5, V6. We also call those the V leads. This is where you place the electrodes. So this is the electrode placement on this chart here. But basically, you're going to have V1, this is V1, and it's going to be labeled V1, V2, V3, V4, V5, V6. So it shows you on that table where to place the leads. But basically, if it's a female, you're going to go right underneath the breast, and you're going to wind up here in the mid-axillary line. So V1 goes here, V2, V3, V4, V5, and then V6. It's under the anterior axillary line. V6 will be at the mid-axillary line. Okay, and so there's actually only 10 electrodes on a 12 lead EKG. So with these 10 electrodes, we're able to see the heart in 12 different directions. So you can put those limb leads, you can put them here, white on right, black on left, red heart, the green one left over. You can put them there, or you can put them on the arms and on the legs. Like here, they have those on the arms and legs. Or you could put them, here, 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 and here. So here's white on right, black on left, red heart, green one left over. And then V1, V2, V3, V4, V5, V6. So there's 10 electrodes, but it's looking at the heart from 12 different directions. So you have 12 leads. And this is the V leads. And the V leads look at the heart like in a horizontal plane. This is V1, it's looking at the heart in this direction, V2 in this direction, V3 in this direction, V4, V5, and V6. So it's a sagittal plane, and it's looking at the heart, the cross section of the heart. So here's the 12 lead EKG, and these are all the waveforms for each of the 12 leads. And so these are the leads that have a positive deflection on the 12 lead EKG. You have 2 leads that have a negative deflection, AVR and V1. So AVR, the QRS is upside down. V1, the QRS is upside down. And then there's 2 leads that kind of wraps around the heart. So you have a positive and a negative deflection, and that's AVL and V2. So they have a positive and a negative deflection, and that's normal on a 12-lead EKG. So last week, I believe it was, we talked about MIs. And we said that different leads look at different parts of the heart. And so I'm going to go back to this picture that I also went over with you when we talked about MIs. So the right coronary artery feeds the inferior portion of the heart, and the inferior portion of the heart is read by leads 2, 3, and AVF. We said that the left main divides into the circumflex and the LAD. The circumflex kind of wraps behind the heart, and it feeds the lateral portion of the heart. The LAD feeds the anterior portion of the heart, and the apex. Apex is also known as the septum. And the leads that read the apex are V1 and V2. The leads that read the anterior portion of the heart are V3 and V4, and the leads that read the lateral portion of the heart are V5 and V6. And so we can look at different areas of the heart on the 12-lead EKG based on what area of the heart they're looking at. And so remember that we talked about ST segment. We said that this ST segment should be isoelectric. In other words, it should be at about the same level, yes? So this case here, this ST segment is isoelectric. But here I have the ST elevation, where instead of starting down here where it's supposed to, it's starting way over here. We said we call that a fireman's hat, right? That indicates ischemia to the point of injury. So if on the 12-lead EKG, the doctor says that there is signs of an inferior MI due to ST elevations, then what leads is this doctor seeing these ST elevation, and what leads if they say that the patient's having an inferior MI? Leads 2, 3, and AVF, right? And what artery is probably occluded? The right coronary artery. What if you saw ST segment elevations in the anterior leads? Then where would you see, which leads would you have this fireman's hat? Well, it would be V3 and V4, and probably also V1 and V2, because probably you have a blockage right here, right? So all of this is not getting perfused. So if you're having an anterior MI, then more than likely you're having an anterior septal MI, because if it's blocked here, it's going to be blocked all the way down here. So it'll be V1, V2, V3, and V4, yeah? What if you saw an ST elevation in V1, V2, V3, V4, V5, V6? Where is the blockage? It's way up here, yeah? It's in the left main. So basically this whole side of the heart is not getting perfused, right? What if you only saw ST elevations in V5 and V6? Where's the blockage? Over here in the circumflex, yes? So you can see that by looking at the 12-lead EKG, the doctor can determine which artery is probably occluded and what part of the heart is being damaged. So we said that the leads 2, 3, and AVF look at the inferior portion of the heart, and that's fed by the right coronary artery. The lateral portion of the heart is fed by the circumflex, and that is read by V5 and V6, as well as lead 1 and AVL. The anterior portion of the heart is fed by the LAD, and you can read that with leads V3 and V4. And the septal, or the apex, means the same thing, is read by V1 and V2, which is also fed by the LAD, left anterior descending. So again, this ST segment, what does it tell us? It tells us that we're perfusing our heart. This ST segment should be isoelectric. If it's isoelectric, we're perfusing our heart. If this T wave is upside down, that indicates ischemia, T wave inversion. This person is having ischemia. You could have T wave inversion, like you have here, T wave inversion, or you could have ST depression. ST depression, this ST segment should have started here if it was isoelectric, but instead it's starting down here. So now we're having ST depression that indicates ischemia. And here is somebody that's having an MI. You see the fireman's hat? Instead of starting this ST segment, instead of starting down here at the isoelectric line, it's starting up here. This indicates ischemia to the point of injury. So remember that when we talked about MIs, we talked about the difference between stable and unstable angina. So let's say that you are a patient that has stable angina. And you know that if you walk up that flight of stairs, by the time you get to that top of that flight of stairs, you're probably going to have chest pain. And you know that when you sit down and rest, it goes away, or if you take the nitro, it goes away. So let's say that you have a Holter monitor on, a portable monitor, EKG monitor, and you have chronic stable angina. You walk up the flight of stairs. You have chest pain when you get to the top of the stairs. What do you think you would see on that Holter monitor when you got to the top of the stairs and you were having chest pain? You would see either ST depression or T wave inversion. But now you sit down and rest, or you take your nitro and it goes away. What's that Holter monitor going to do? This ST segment will come back up to the baseline. It will be isoelectric, and this T wave will turn upright. These are reversible. If you get oxygen to the heart, these are reversible. Now, let's say that that same patient got up to the top of the stairs with their Holter monitor. They sat down and rested. Pain didn't go away. They took their nitro. 5 minutes later, they're still in chest pain. So now what do? You call 911. So while they're waiting for the ambulance, they go ahead and took another nitro. And the ambulance arrived 10 minutes later, and they're still in excruciating pain, and they've had 3 nitro and it wasn't relieved. What do you think you might be seeing on that Holter monitor now? You might be seeing ischemia to the point of injury. Yes, it wasn't relieved, and they're still having ischemia. So now the cells are starting to be injured, and that's when you see this ST elevation. If you get oxygen to the heart before it dies, this is also reversible. It will come back down to the baseline. It will come back down to the isoelectric line. So these EKG changes are reversible. So if you see a EKG pattern that looks like an action potential, you should have learned about action potentials in A&P, then it will look like a fireman's hat, right? This is what an ST elevation looks like. Keep in mind that if you see a fireman's hat, it looks like an action potential, death is imminent. We only have about 20 minutes to get oxygen to that heart before that heart muscle dies. So here we have somebody that is having an acute inferior MI. How do we know that it's an inferior portion of the heart? Because we see ST segment elevations and leads 2, 3, and AVF. And what artery leads the inferior portion of the heart? The right coronary artery. So probably this person's right coronary artery is occluded. So again, to recap, we should have this ST segment should be isoelectric. That tells us whether or not we're perfusing our heart. If we have ST elevation, that indicates injury. It's ischemia to the point of injury. ST depression indicates ischemia. So the ST segment starts below the isoelectric line. Now here is a normal Q wave. The Q wave should be less than this. It's usually less than a little box. If it's more than 2 little boxes, and in this case it's 1, 2, 3, 4, 5 little boxes, this is a pathologic Q wave. This is not reversible. Once you get a Q wave, you're going to have a Q wave forever. It indicates dead tissue. Why is it irreversible? Because once your muscle cells die, they're dead forever. They do not regenerate. So this indicates an infarction. So what if you had pathologic Q waves and leads 2, 3, and AVF? What does that mean? That means that person had an inferior MI. Part of that inferior muscle is dead. And at some point, that right coronary artery was occluded. So here you see a pathologic Q wave. It's more than 2 little boxes. They're going to have this for the rest of their life. It's irreversible. It indicates dead tissue. So here we have somebody that has a Q wave and leads 2-3 in AVF. What does that mean? That the inferior portion of their heart is dead. Yeah, so that muscle is not moving the way that it's supposed to move. So here we have a normal Q wave, so you can see it's less than 2 little boxes. And here we have a very pronounced Q wave, right? It's like 8 boxes. Okay, so let's take a small break here. And then when we come back, we're going to talk about rhythm analysis. Okay, we're going to continue with rhythm analysis. And so I'm not going to read this slide to you, but these are some indications of why your physician or healthcare provider would order cardiac monitoring. So I'll let you read that on your own. Now, when you're reading and analyzing an EKG, your EKG strip, those EKG strips have these small squares on them. And each one of those squares, if you go in this direction, it's measuring time in seconds. And if you go in this direction, it's measuring voltage. Now, when you're measuring time in seconds, each one of those little boxes is equal to 0.04 seconds. There's 5 little boxes in each big box, right? So there's 1, 2, 3, 4, 5 little boxes in each big box. So if each one of these little boxes is 0.04 seconds, how many seconds is one big box? Well, 5 times 0.04 would be 0.20, right? So each one of those big boxes is 0.20 seconds. 15 of these big boxes is a 6-second strip. And we generally analyze, 15 of the little boxes are 3-second strip. And we generally analyze 6-second strips. So how many boxes would be in a 6-second strip? 30, right? So when we're analyzing EKG strips, we usually analyze a 6-second strip, which is 30 boxes. Now on the on this waveform, each one of these waveforms indicates something on the EKG, right? It corresponds with the electrical activity of the heart. And so this P wave is going to correspond with atrial depolarization. This QRS corresponds with ventricular depolarization. This ST segment is when the heart is at rest. And this T wave is ventricular repolarization. So again, when you have a 6-second strip, you usually have these tick marks. You usually have tick marks every 3 seconds. So how many boxes did we say is in 3 seconds? 15, right? So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, right? So that would be 3 seconds. And then over here would be another 3 seconds. So this is a 6-second strip. So there's 30 boxes in a 6-second strip. This is the action potential that I told you about earlier. So one action potential, one depolarization and one repolarization is equal to an action potential. So in the resting state, in the polarized cell, the sodium and calcium is outside the cell, the potassium's inside the cell. That's how come if you give somebody too much potassium, their heart stops. The heart will be in continuous rest, right? Because when the potassium is inside the cell, the heart is at rest. That's how come we never give potassium IV push, because it'll stop the heart. It needs to always be in a piggyback. It needs to be diluted. Potassium comes out of the cell and sodium and calcium go into the cell during depolarization. This is when contraction occurs. This is when we see the QRS. This is what's happening in the QRS. And then during repolarization, our heart we said is vulnerable. This corresponds with our T wave. When the sodium and calcium are leaving the cell and the potassium is going back into the cell, that's repolarization. So the pacemaker of the heart is the SA node. So the SA node is the pacemaker of the heart because it beats the fastest if everything's working properly. There are other pacers in the atria that could take over if they were faster, but usually the fastest pacemaker, if everything's working properly, is going to be the one that takes over, and the SA node takes over because it's the fastest. It's going to beat somewhere between 60 and 100 times per minute if everything is working properly. And then, so the SA node initiates a beat, the action potential occurs, and it depolarizes the atria. And then the beat goes down to the AV node, where it slows it down. So when it gets to the AV node, it slows down that beat to 40 to 60 beats per minute. And so then it goes down the bundle of His and up the Purkinje fibers. And when it does that, it causes an action potential in the ventricles, and the ventricles contract. Eventually, the entire heart returns to the resting state, and it remains there until another action potential is generated in the SA node. So the SA node is the pacemaker of the heart. When it's working properly, it's beating between 60 to 100 beats per minute. So here we have a normal action potential. Starts off in the SA node, goes through the atria contracts, goes to the AV node slows it down, goes down the bundle of His, then up the Purkinje fibers, and the ventricles contract. And then you go through the same cycle over and over again. I'm not sure if this is going to work. Let me try it. Actually, I'm going to let you do that on your own. So just copy and paste this onto your web browser and see if you can see this animation of a conduction system. It's very short. It's a little clip. Okay, the P wave. The P wave is electrical stimulation of the atria, and it's produced as an impulse from the SA node and the AV junction causing atrial contraction. So the impulse starts in the SA node, it goes to the AV node, and when that occurs, it causes the atria to contract, to depolarize. The QRS is the time to depolarize both ventricles, and here's the QRS. It's conduction of impulses through, what you're seeing here is the conduction of impulses through the bundle of His to the Purkinje fibers, which causes contraction of the ventricles. So what you're seeing here is contraction of the ventricles. And one of the things we measure when we're analyzing an EKG strip is the QRS interval. So we're going to measure the amount of little boxes between the beginning of the Q wave to the end of the S wave. And it should be less than 3 little boxes. It should be 2 to 3 little boxes. If it's between 2 and 3 little boxes, we call that a narrow QRS. If you have a narrow QRS, you know that that beat is being initiated somewhere in the atria. Because if it's being initiated in the ventricles, that QRS is going to be wide and bizarre. So if the beat is being initiated in the atria, that QRS is going to be narrow. It's going to be between 0.08 and 0.12 seconds. So somewhere between 2 and 3 little boxes. And what does that measurement indicate? It represents the time required for the electrical impulse to depolarize both ventricles. So this is what we're measuring, the time that it takes to depolarize both ventricles. It should take between 0.08 to 0.12 seconds. The T wave is electrical recovery of the ventricles. This T wave is ventricular repolarization, right? when the sodium and calcium are going out of the cell and potassium are going back into the cell. We said that our heart is vulnerable at that time, because if you were to initiate an electrical charge here, your heart would stop. And there's what's called a refractory stage, a relative refractory stage that occurs here, that if you were to initiate an impulse during that relative refractory stage, you could stop the heart. And that occurs here in the T wave during ventricular repolarization. So that'll become important when we talk about code management. Okay, so on the EKG, the P wave corresponds with atrial depolarization. The QRS corresponds with ventricular depolarization, and the T wave represents repolarization. They're getting ready for the next series of complexes. Another thing that we measure when we're analyzing an EKG is the PR interval. The PR interval is measured from the beginning of the P wave to the beginning of the QRS. So you're going to count the number of boxes from the beginning of the P wave to the beginning of the QRS. And what are we measuring there? We're measuring the time it takes to get from the for that impulse, from the electrical impulse, to get from the SA node to the Purkinje fibers in the ventricles. And it should be between 3 and 5 little boxes, between 0.12 and 0.20 seconds. So you're going to, again, measure from the beginning of the P wave to the beginning of the QRS, and it should be between 3 to 5 little boxes. And what are we measuring? The time it takes to get from the SA node, for that electrical impulse, to get from the SA node to the Purkinje fibers. The ST segment will tell us nothing about the rhythm, but will tell us about what? Perfusion of the heart, right? We're looking to see that it's isoelectric. It may be elevated or depressed if we have myocardial ischemia. So this ST segment should be isoelectric, should be about the same level as that. The QT interval. The QT interval is not part of the regular analysis of an EKG. It doesn't really tell you anything about the rhythm, but there's certain drugs that prolong that QT interval. And if your patient is on that drug that prolongs the QT interval, you need to monitor it. Because when that QT interval gets prolonged, it can cause ventricular arrhythmias, which are life-threatening. Torsades de Pointes is a type of VFib that occurs secondary to QT interval lengthening. So if your patient is on a type of drug that prolongs the QT interval, then it's going to be your nursing responsibility to monitor that QT interval. And it should be between 0.36 to 0.44 seconds. So if you're on that type of drug, then you would need to monitor the QT interval. One of those drugs is amiodarone. So people that are on chronic amiodarone, you need to monitor their QT interval. Okay, so here we have the P wave. The P wave is corresponds with atrial contraction from when the impulse goes from the SA node to the AV node. The QRS complex is conduction of the impulse to the bundle of His and the Purkinje fibers, which causes ventricular contraction. This ST segment is the heart's resting period, and it should be isoelectric. It tells us about perfusion. The T wave corresponds with ventricular repolarization. And we also want to measure that PR interval. That PR interval is measured from the beginning of the P wave to the beginning of the QRS, and it should be between 3 and 5 little boxes. And that's measuring the time it takes to get from the SA node to the Purkinje fibers. The time it takes to get for that impulse to travel over here and cause ventricular depolarization. So any cell in the heart has the capacity to be a pacemaker. If you heart cells can beat on their own, and they have the capacity to be the pacemaker of the heart. Normally, the SA node is the pacemaker because it's the fastest. It beats between 60 to 100 times per minute. The fastest pacemaker will override all slower pacemakers and reset them to 0. So therefore, theoretically, the slower pacemaker should never fire. The next fastest pacer is the AV node. The AV node is also known as the junction, is known as the junctional pacemaker because it sits at the junction of the atria and the ventricle. And it paces at a rate of between 40 to 60. So it goes from the SA node to the AV node, and the AV node slows down the heart, the pace of the heart. And then the slowest pacers are in the Purkinje fibers and in the ventricular muscle, and they pace somewhere between 20 and 40 beats per minute. So if the SA node stops working and the AV node stops working, or the AV node is blocking all of the electrical activity that's coming to the ventricles, then the ventricles will take over, the Purkinje fibers will take over, and they'll beat on their own at a rate of 20 to 40. And we're going to talk about some heart blocks where that happens. So the atria can also become pacemakers. The atrial cells can also become pacemakers. And in disease states, they can be very fast. So we're going to talk about some arrhythmias where your atria is beating very fast because the atrial cells have become pacemakers and are overriding the SA node. So when any part of the heart, other than the sinus node, is the pacemaker, the new beats are called ectopic beats, and the pacemaker is designated as an ectopic pacemaker. So there's 5 steps in analyzing a rhythm strip. The first thing you want to do is measure to see if it's regular or irregular. So you can take some calipers and open them up from one QRS to the next, and then that same distance in the calipers, you leave it there, and it should march out. The next set of QRS should be the same distance, right? And so you can march it out to see if it's regular or irregular. And then you want to assess the rate. Is the rate between 60 and 100 beats per minute? So what you can do is count the number of R waves in a 6-second strip and multiply by 10. So this is a 6-second strip. I've got a tick mark at every 3 seconds. So what I'm going to do is I'm going to count the number of QRSs in between those tick marks, right? So I got 1, 2, 3, 4, 5, 6, 7 QRSs in a 6-second strip. I'm going to multiply that by 10, and this person's heart rate is approximately 70. If I want to know the exact amount, then I'm going to count the number of little boxes in between 2 QRSs and divide that 1500 by that number. So let's look at this one. This one starts right on the line, so this will be easier to count, right? So that's 5, 10, 15, 20, about 23 little boxes. So if you were to take, let me see if I can get the calculator up. Let's see. Okay, so hopefully you can see my calculator. So I divide 1500 divided by 23, and that's going to equal to 65. So this person's actual heart rate is 65 because I divided 1500 by 23, which was the number of little squares in between 2 QRSs. But if you were to do it where you're just counting the number of QRSs in a 6-second strip, it would be 70. So it's pretty close. But if you want the exact number, you can do this division. So is the rate between 60 and 100. And then step 3 is to assess the P waves. There should be one P wave in front of every QRS, and they should look similar. So in this case, there's a P wave here, 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 P wave here, and there's a P wave in front of every QRS, and they look similar. They don't have to look exactly alike, but they look pretty similar. Yeah, so you want one P wave in front of every QRS, and they should look similar. The next thing you do is assess the PR interval. Is it between 0.12 and 0.20 seconds? So is it between 3 and 5 little boxes? So you start from the beginning of the P wave to the beginning of the QRS, and you count the number of boxes. 1, 2, 3, a little less than 4. Is it between 3 and 5 little boxes? Yes. If the answer to that is yes, that's normal. So you're going to measure from the beginning of the P wave to the beginning of the QRS. And then you want to look at the QRS interval. Is it narrow? Is it 3 little boxes or less? And in this case, yes, it's a little over 2 boxes. That is less than 3, so that's normal. So is the QRS interval 3 little boxes or less? And if the answer to that is yes, you have a narrow QRS, and that's normal. It's coming from the atrium. So when do you have a normal EKG? When the atrial rate is regular. So you march out the P waves, and they should all march out. In a minute, I'm going to show you how to do that. You're going to do that with calipers. You can do it with a piece of paper as well. Does the ventricular rate march out? Is it regular? Again, with calipers, does it march out? The ventricular rate, you count the number of QRSs in a 6-second strip multiplied by 10. Is it between 60 and 100? You look at the P wave. Is there one P wave for every QRS, and do they all look similar? That QRS interval, is it less than 3? Is it less than 3 little boxes? 3 little boxes or less? If the answer is yes, it's narrow, and that's a normal finding. The PR interval from the beginning of the P wave to the beginning of the QRS, is that between 3 to 5 little boxes? And if the answer to that is yes, that's normal. So that's what you need to know to analyze a rhythm strip, to know what kind of rhythm the patient's in. Other things that you can consider as you're looking at a rhythm strip is that QT interval. When do we measure that QT interval? There's certain drugs that prolong the QT interval. And if that QT interval is prolonged, they're at risk for ventricular arrhythmias, such as Torsades de Pointes. And we'll talk about that when we talk about code management. You want to look at that ST segment. Is that ST segment isoelectric? Is it elevated or is it depressed? That tells us about the perfusion of the heart. It doesn't tell us anything about the rhythm. It just tells us whether or not the heart is being perfused. The T waves, are they upright and are they of normal height? So T waves, if they're inverted, could indicate ischemia. If they're tall and peaked, it could indicate hyperkalemia. So you want to know if they are of normal height. All right, and so we are going to analyze some strips together. I'm going to have to go to another computer to do that. And so I'm going to go ahead and end this recording here, and I'm going to start a new recording where we're going to analyze some strips together. Okay, see you soon.